Hello, Gitku. We are so excited to have you back. I feel like I haven't been at Academic Half Day in a while, so nice to see your names and a few faces. We have a variety of Gitku legends coming to us today to teach about um, immigrant and refugee health, including things like communication in non-English encounters, trauma-informed care, and like a great case-based discussion to round out our day. Um, so I'm excited to introduce Shri and Alex, who are going to take it away this morning.
Yeah, thank you, Nikki. So I recognize some faces as well. So thank you all for being here. My name is Shri. I am a former internal medicine resident. Graduated now 2 years ago. Was the outpatient chief resident at Adult Medicine Clinic, and now practice primary care at Harborview. And Alex, I'll let you introduce yourself.
Right on. I also see some familiar faces. I did med school at the UW, went away for residency, sadly, but then was lucky enough to return to Harborview 17 years ago and have been practicing at the International Medicine Clinic, and for 9 years was also at the Pioneer Square Clinic, um, and spend about half of my time teaching at the medical school with first and second year students, and am excited to be on board with Shree's Magic today. And so I look forward to discussing all these important issues with all of you.
Yeah, and we'll be joined a little bit later by Nicole Ehrenholtz, who is in clinic right now, but we'll be giving the second talk. So we'll introduce her when she's on. So here's our overall agenda, just so you all can plan your breaks and snack activities for the morning. But with that being said, let's get started. So our first talk for this morning, we're going to focus on communication, specifically in encounters where the primary language is not English. I don't have any disclosures to share with you today, but I do have some acknowledgements. I wanted to shout out the work of Abdi, one of your co-residents, and Anab Abdullahi, who is a caseworker, cultural mediator for people who speak Somali. Duncan Reed and Kim O'Connor, who are internists at Harborview and UW, respectively, and then the School of Medicine Foundations of Clinical Medicine team. They put together some of the content for this presentation and use it in their teaching in the medical school. But it's excellent and I think relevant for us as well. So learning objectives, we're going to approach caring for immigrant patients using an equity-based approach, understand some common pitfalls and potential solutions when using an interpreter. And then I think, as is the theme for this presentation, I think learning from each other. When I was thinking about how to put together this presentation, I was like, oh, should I use polls? Should we use group-based discussion? And I think the big takeaway is that there are very few right answers in how you approach communication, and a lot of right answers. And so really, I think we hopefully can learn from each other. I don't think that polls and you know ABC answer choices are really best suited for this type of topic. So uh, we'll get started with that. So I want to start off with just highlighting that we as doctors are educators, uh, not only educators for the other trainees around us, but educators for our patients. And you've heard this before through the residency program and through, I think, probably the folks from the health equity pathway. Um, but health equity is something that we need to incorporate into our education. And I included a figure here, which maybe you've seen before, basically highlighting the difference between equity and equality in this kind of metaphor of a baseball game where people are trying to peek over the fence to enjoy the baseball game. And you see on the left what is equality. Each one is getting one box, and some are left unable to see. versus equity, in which the boxes are redistributed in a way that allows everyone to enjoy the game. But I wanted to take this figure a step further and think a little bit about the fence that's there in the game and why that fence is there and what it comprises of. And I've put together three things here. You know, one is the patient factors, their own sense of self-worth. You know, do they feel like they can advocate for themselves within our health system? The provider factors are implicit bias and our complacency with the status quo, how things are, saying, this is just how it's going to be, and we just have to get behind that. And then the system factors, which I didn't really dive into too deeply here, but it is actually one of the largest pieces of this and most complex pieces of this. But I'd like us, as we are having our discussions today, to think about how we can tear down this fence and make things easier so that people can just enjoy what they need to. With that being said, let's get started with a case. This is a patient that was on Harborview Cardiology now 2 months ago, one of my primary care patients. So 62-year-old Guatemalan man was admitted to Harborview for headache and chest pain. He was in the ED and had a CT head which showed a vertebral artery occlusion. That was done for his headache. And then simultaneously had lab work showing troponin elevation. Initial troponin was 0.09, and then subsequent troponin 4 hours later jumped to 0.34. Neurology was consulted in the ER for the vertebral artery occlusion and thought it was chronic and recommended medical management. So he was ultimately admitted to cardiology for treatment of an NSTEMI. And he underwent PCI, the culprit lesion in the RCA, and he was discharged 3 days later without patient follow-up, that being myself and cardiology a few months later. So he comes to clinic to see me, and this is within a week of discharge. And I see him with an in-person Spanish interpreter at the Pioneer Square Clinic. And I ask him, what happened in the hospital? And this is what he says, as interpreted by the Spanish interpreter. As I was asking him, what is your heart okay? And he said, I don't have any heart problems. I was told that I had a stroke in the hospital. And I think this is a really common occurrence, how we communicate things and what patients take away from our communication. And so this exemplifies what I'd like to talk about today and how we can prevent this type of misunderstanding and really ensure that patients are in the driver's seat for their health. A little bit of data to share with you as well regarding health and English proficiency. So 1 in 5 adults in the United States speak a language other than English at home. That's a huge amount. And we need to find a way of caring for them in an equitable fashion. The federal government has tried to do so by creating these national standards for culturally and linguistically appropriate services, CLAS. They're a little wordy, so I abridged them. And basically the 4 main tenets that pertain to interpretation are that hospitals should provide free interpretation. They should inform patients of interpreter availability in their language, train interpreters, and create media and signs in the most common languages that the hospital cares for. But this is an unfunded mandate, and so hospitals are not paid to do this. In fact, if they don't do it, they're at risk of losing some of their insurance reimbursement. And so it's hard to implement. And I think that our health system has done an incredible job of working on this, and still not perfect. There was a study in 2010 at Yale where they surveyed 135 hospitals across the country that were geographically and demographically diverse. And this graph is kind of confusing to look at, but basically, 20% of those hospitals surveyed didn't meet any of the standards. Like they were not even providing free interpretation. And then basically only 13% met all of the standards. So really this kind of now dated study suggests that hospitals are really struggling to implement this. And so that's important for us to know as we continue through residency, but then also move forward to your next steps in your career, either in public or private hospitals, because I'm sure you'll encounter this and encounter issues with interpreter access. And then a little bit about the data. I didn't cite the data here, but there's a number of systematic reviews on this topic. Basically, patients with limited English proficiency have worse health outcomes, decreased use of preventative services, decreased cancer screening, and this is all improved with language concordant care. I have some references that you all can look at on your own time. So with those kind of introductory slides out of the way, now I want to transition us to kind of the more interactive, fun portion of this talk. So looking at communication using an interpreter. And we have 2 videos to reflect on this morning. And while we're watching these videos, I'd like you to imagine that you have recently moved to Somalia. You finished your residency and maybe you're doing a medical mission abroad, or you decided residency wasn't for you and you wanted to do something else. And you're now navigating a new environment, a little bit of a stressful situation. You haven't lived in Somalia before. And after a few months of living there, you decide to prioritize your health and see a doctor for a checkup and establish primary care. So that's a responsible thing to do. On your first visit, the doctor orders some blood work, and you are now returning to discuss the results. So here is the first video that we are going to watch. And following this video, we're going to enter breakout rooms, and then we'll have some small group discussion. So just reflect on the video, and then we can talk about it in small groups. And let me know if you can't hear anything.
ku soo dhawow xarunteena caafimaadka ah waxaan ku hayaa jawaabihii dhiigga laga qaaday usbuucii lasoo dhaafay.
Welcome to our clinic again, and I have the test result that has been done last week.
wax kasta waxay ahaayeen normal sida loogu talagalay marka laga reebo baarista tiibishada anagoo isticmaaleen interferon gamma kaas ayaa wuxuu noqday positive.
Everything else was normal when only the test of gamma interferon assay test that was negative positive.
waxaan rabaa inaan maanta arrintaasi aan ka hadalno sidii lagu daaweyn lahaa loogana hortegi lahaa problemka taas ayaana maanta ka hadli doonaa.
I want to talk about that interferon test, and the reason is because all other tests was negative except that one that I want to talk to you about it and how we can treat for them. Waa maxay interferon assay test?
dhib ma lahan interferon gamma waa wax hadda cusub aan isticmaalno oo aan ku baarno tiibishada jawaabihiisana si saxsan ayuu u noo siiyaa. waagi hore waxaan isticmaali jirnay wax loo yaqaano mantoux test oo aan ku baari jirnay dhinaca maqaarka ah laakiin ma u baahna ayada waxaas inay kala ogaato.
I asked him what was interferon test, and interferon test is a newly test that they check for the TB. Before they used to use the mantoux test for the skin test, but he said that you don't need to know all that stuff.
mideeda kale raajadeeda waxay ahayd normal waxaa kaloo sheegtaa ma qabto calaamadaha sida ha noqoto qufaca oo kale iyo wadna xanuun waxaana u haynaa dadka noocaas oo kale 4 daawo lagu daaweeyo.
Your chest X-ray was negative. You don't have any symptoms for TB like a cough or fever, and there is 4 different medication that we treat people that has a TB like you.
waxaan siinaynaa daawooyinka loo yaqaano isoniazid 9 bilood ayaa siinaynaa. waxaa iskugu dari karnaa rifampin iyo isoniazidka 3 bilood ama waxaa siinaynaa isoniazid iyo rifampin usbuucii hal mar ayadoo qaadanaysa 3 bilood ama kan ugu dambeeya oo ah rifampin keligiis 4 bilood.
Yeah, there's 4 different treatment: isoniazid for 9 months, isoniazid and rifampin for 3 months, isoniazid and rifampicin every week for 3 months and rifampicin on 4 months.
So, do I have tuberculosis?
Ma TB baan qabaa.
ها u sheeg TB aa lagaa hela dheh waxaana kuula talin lahaa inaad daawada qaadatid.
Yes, they found out that you have a TB and I would recommend you to take the medication.
una sheeg daawada rifampicin-ka ayaan ula talin lahaa inay qaadato waxayna soconaysaa 4 bilood daawadaasi waxay bedeshaa kalarka kaadidaada laakiin waxniisa ka walwalin.
I would recommend you to take rifampicin. That's the treatment I want to give it to you, and that medication lasts for 4 months, and it changes the color of your urine in orange, and you don't have to be worried about it.
All right, so hopefully this kind of flipped video where we're now listening to a doctor in Somali explain this to us has inspired some thoughts in you. So let's go into some breakout rooms, and I just want you to reflect on how you felt in this visit, putting yourself in the shoes of the patient. We'll come back after 5 minutes. Yeah, go ahead, Alex.
And I just want to remind you that this was not meant to be an amazing example. So you may have noticed at the beginning it said maybe using some less effective communication techniques. So this, you are not insulting Abdi by saying these are the things that I would do differently. This is an opportunity for reflect on what worked and what didn't work in that encounter. And so that is your opportunity here.
Awesome. So let's go into breakout rooms and we'll come back around 9:26.
Javel, are you able to help us?
They should be entering them now.
Okay, great. Thank you. Okay,
Nicole, you were able to enter so early, Nicole. That's great.
yeah, we should make sure to welcome you when the groups
Oh.
come back.
Thanks. Yeah, my earlier patient is probably my least high maintenance patient ever, and she was early as usual. And yeah, it's all good. So everyone else will be later.
Yeah. Nikki, do you want to hit pause on the recording? Nick.
All
Thanks.
right.
Back.
Welcome back, everyone. So I'd like to just take a few minutes to hear from the group. How did this feel? Anyone want to share?
I'm seeing overwhelming in the chat. Anything you might have done differently or done the same way?
Our group talked about had a lot of great ideas. And I think one of the things that we initially talked about was, kind of having an outsider view or a bird's eye view of that dynamic, was kind of like what percentage of the conversation each person had. And, it felt very much a conversation almost that the bulk of it was the provider and interpreter, and then the patient mostly just kind of took in the information as it was being interpreted and had less of a role in kind of like a closed loop, now saying something in return to the provider, asking a question. And one of the things that we talked about was how sometimes minimizing how much you say each time and allowing for that to be interpreted. So instead of kind of saying 3 or 4 sentences about lab results, going one at a time, or picking the one thing you really want to talk about and saying that separately from everything else to allow the patient to ask a question. One of the things that we noticed was that the question about, oh, so do I have TB? It came up at the end versus earlier. Maybe that was something that could have been asked earlier if there was a little bit more space in between the information that was being provided. And another thing that someone had mentioned was how eye contact can actually help in that interaction. So eye contact between the provider and the patient versus provider and interpreter, it allows you to kind of assess whether or not there's a state of shock with the news that's being delivered, and allow you to open up avenues to ask the patient, have you heard about this before? What are your thoughts? This can be a really scary, test result, just to kind of go down that part of a conversation as well versus just sticking to the science and medicine of it. But one thing that I think did go really well is that I think our interpreters are amazing at Harborview, and they can kind of gauge sometimes the questions that patients would have just from their own personal experience. And the interpreter asked, "Oh, what is an interferon test?" And kind of already anticipating that that was something that many of us, unless we work in the medicine field, wouldn't quite know what that means.
I love that, Jessica. Thank you so much for those reflections. Other ideas about what might have helped this go a little better?
Something our group talked about is that the way that Abdi kind of like framed that conversation by talking about how one of the labs was abnormal and then what that meant and then what medication you would need to take is like probably how we would maybe format that conversation if we were talking to somebody who had like very good health literacy or who does speak like Somali as their primary language. But in this situation with the use of the interpreter, it felt like a lot of information was getting missed, like the point about this patient having latent TB. And that maybe a more effective structure for the conversation would have been starting with like kind of a headliner and being like, this, your lab tests look concerning for latent TB, and then kind of providing more space for the patient to react or be able to ask questions or have a conversation, because this conversation did seem pretty one-sided as well.
That's so outstanding and so true. And I think it's important to remember that even folks who are language concordant with us as providers and have a lot of education, latent TB is confusing, right? And so that kind of bringing that preface in, like you say, Meghna, and then pausing and sharing a little bit about what that means before diving into the details can be really helpful. There's a great comment in the chat. Agreed. Our team was also saying that we would have liked to leave more time for the patient to respond, contribute to the conversation. Teach back would have been great too. And boy, teach back would have been so awesome here. Does anyone have favorite phrases they use for teach back? Feel free to drop them in the chat. One of my favorite is, I just want to make sure I'm explaining this well. What is your understanding of what I just said? But maybe there's some other good ones out there. Shri, I hand it back to you.
All right. Yeah. Thank you for these thoughts. I'm learning a lot from you all as we talk as well. I think my reflection is I like to talk, and I can see myself. I've done this before, exactly what Abdi did. I've done it before. And so maybe some of you like to talk as well. And it's just a cautionary tale. But let's listen to Abdi take 2. And then we'll go back into breakout rooms and do the same thing. All right, let's see. So this is more effective communication.
kusoo dhawaw xarunteena caafimaadka ah magacayga waxaa la yidhaahdaa Dr. Mohammed.
Welcome back to the clinic. My name is Dr. Mohammed.
Hi, I'm Jenny.
Magacayga Jenny baa la dhahaa.
barasho wanaagsan anigana magacayga waxaa la yidhaahdaa Dr. Mohammed barasho wanaagsan.
Nice to meet you. My name also is Dr. Mohammed and magacayga waxaa la yidhahdaa Canab. Waxaan ku hadlaa luqadda Soomaaliga iyo Ingiriiska waxaan ahay turjubaan.
Okay. Sida mar dhaweed aan kulannay waxaan ku hayaa jawaabihii baaristii usbuucii lasoo dhaaf aan sameynay ka hor intaan u gelin sidee tahay xaalkaaga sidee dareemaysaa maanta
waxaan hayaa I have the test results of last week, and before we start talking about the test results, how are you doing?
Oh, I'm actually feeling a lot better. Yeah, thank you.
Aad iyo aad baan u fiicanahay waad mahadsan tahay.
Okay, baaristii aan sameynay waxaa ka mid ahayd dadka inaan ka baarno qaaxada ama tiibishada.
The test we did one of the tests that we did was like to check if there's any TB, if you have it.
Akhbaarta fiican awooda maanta waxa weeye baaristii guud ha noqoto keliyaheeda ha noqoto beerka dhiigga kulli waxay ahaayeen normal sida loogu talagalay.
The good news that I have today is all the blood test results we did it for your kidney, for your liver, your blood count, all of that was normal.
ha ahaatee waxaa laga helay tii qaaxada dhiiggeeda ayaa laga dhex helay.
But we found out that you have TB.
badanaana waxaan ka barnaa TB-da dadka jooga Soomaaliya muddo badan maadaama Soomaaliya ay ku badan yihiin cudurka qaaxada loo yaqaano.
Normally we check the TB people who've been in Somalia for a long time, and the reason is because normally we know that Somalia has a high prevalence of TB.
weligaa ma laga helay qaaxo ama TB-sho noloshaada?
Have you ever been told that you have TB in your life?
No, no, I've never had TB.
Weligay ligama sheegin, weligay iguma dhicin TB.
Okay, dhib ma lahan maadaama hadda Soomaaliya muddo badan ku nooleed ma la kulantay ama ma la nooleed qof qabo cudurka TB-shada ama qaaxada?
I understand, but since you were in Somalia for a while, have you ever been around somebody who has active TB or other people who has a TB?
I don't know anyone who has TB, or at least not to my knowledge.
Ma garanayo qof oo cudurka TB-da qabo aan aniga ahaan aan ogahay.
dhib ma lahan maadaama cudurkani dadka qabo calaamado ma sameeyaan marka ugu horeyso waxaana ku magacaabnaa qaaxada hurudo ama qaaxada jiifto.
Badanaa normally that people who has this kind of TB, it's called latent TB, and they don't manifest or have any symptoms.
waxaa jirto khatar ah in cudurkan hurdada ka soo kaco oo hadhow dhib ku kaysto sidaas awgeed waxaan sameynaynaa inaan daawada aan bilowno aan kugula talino.
Normally when we worry about this is people who has a latent TB, that this TB might come back in the future and cause them more problem. Because of that, we normally offer them medication to take.
Okay.
akhbaarta fiican aan ku hayo waxa weeye raajadii lagaa qaaday waxay ahayd mid normal ah maadaama hadda calaamado aadan qabin oo aadan lahayn sida qufaca oo kale arintaada waxaan u maleynayaa inay tahay arin la daaweyn karo haddana wax laga qaban karo.
Good news that I have your chest X-ray was negative. You don't have any symptoms of TB, and I think your situation there's something we can do.
wax su'aalaha ma qabtaa maanta?
Do you have any questions today?
I guess I'm surprised that I have TB, and I want to know, am I contagious? And is it okay? Can I go home to the United States, or like, what does this mean?
aad baan uga yaabay ku tiri inay ku dhahay markan cudurka TB-da ayaa qaba. Taas micnaheedu miyaan dadka miyaan ku daaran karaa? Miyaan tegi karaa United States waddankaygii miyaan tegi karaa? Mise inta meeshan jooga wey?
kuwaas dhan waa su'aalo fiican. number 1 maadaama hadda aadan calaamadihii lahayn raajadaadana ay tahay normal cudurka hadda ma gudbin kartid oo qof kale kuma daarin kartid.
All your questions are very valid questions, and because of your chest X-ray was normal, you don't have any symptoms. This kind of TB, you're not contagious.
waana safri kartaa oo waddankaaga waa aadi kartaa.
And you can travel and go to your country.
sidaas awgeed waxaan kugula talinaynaa inaan hadda bilaawno daawo.
Shri, you're muted. I think there was a technical difficulty.
Sorry, that was my bad.
We probably I think we got a good idea, a good sense
Yeah.
of that discussion, so we can reflect on that. Does that feel okay?
Yeah, that sounds good. So let's go back into breakout rooms. We'll come back at 9:44.
And just, take a minute and notice some of the things that were done differently. And if there's anything in that toolkit that feels like you would want to use or that you felt like worked particularly well or things you might do differently, this is a chance to reflect on those with your colleagues and share your wisdom.
Okay, breakouts are open. Some of you I see are not assigned. If you just joined, let me know. Or if you were in a group previously, let me know the name of someone you were in the group with, and I can get you back in there.
I think I need a new group. This is Sophie, but I'll.
Thanks, Sophie.
Hi there. This is Ryan. My internet got cut off, and I was in a group with Lucia.
Okay, 1 second. I will get you back in.
Thank you, Javel.
Sure.
Zoom wizard.
Room 6.
I need to get you a t-shirt that says that. Right. Yeah, that's great. I'm gonna step off in a little bit just so I don't interrupt as I leave. I'm gonna put in the chat that reference that I mentioned because I think it's tremendous. And then I also downloaded it, and if I can figure out how to do it, I'm gonna put it into the chat so that you can reference it. It's like one of my favorite articles ever, and it's really beautiful in its simplicity, and it's really nuanced and not saying that it's all bad or all good. And it's really I think when I talk to people about good examples of qualitative research, it's really super well done. But and it's our people, right? Like it happened at Harborview MICUs. It's like as high stakes as it gets. And so if there's ever a situation in which interpretation is going to be looked at and carefully done, it's going to be in this high stakes end of life discussions. And still there are a lot of things that were both positive and negative about how the interpretations went. But I will.
Yeah, that sounds great. I referenced that article.
Oh, you do? Okay.
A little later. I don't know why I have the exact name. So if you share it, that would still be good. Yeah.
Yeah, it's from CHEST. It's the title's Alterations During Medical Interpretation
Yeah.
of ICU Conferences That Interfere with or Enhance Communication. And you know, I think many people won't have known Carrie Jackson or Randy Curtis. Yeah, but you know, they're the senior authors on this paper.
I thought you were going to reference Getting By, which is out of UCSF, which was written by Yale Schenker and a group there about people using their own substandard language to try and get by, right? When what they need is a professional interpreter. That one I reference a lot with my students and residents as well.
I will say that one of the struggles that I have personally, and again, I'm interested if people say this as they come back, will be the families that insist that will not accept a professionally trained interpreter, and I don't feel like I have great script necessarily. I have some things that I try, and when trying to build rapport or maintain rapport, I find that personally very challenging.
Yeah, I usually just fall back on the law is that a professional interpreter be available, and so I'm just going to dial this person in, and they'll be our backup.
Yeah.
Yeah. And so it's on me not wanting to get in trouble with the law, not on me telling them they can't have what they want.
Yeah. I should probably be a little bit less permissive in the way that I interact in that way. Oftentimes, I find it particularly with patients who maybe others have had some challenges with connecting with or are mistrustful for other reasons and such. But again, I'm going to step off. Thank you all for doing this. This is fabulous. And if you have a chance to tell Abdi, I think he has a second career as an actor in his future, perhaps.
We'll pass it along.
Yeah.
Bye, John.
Bye.
All right. Welcome back, everyone. So what do y'all think? Any reflections from this last video we saw? Anything that felt different? We'll just take a couple minutes and then we'll move on.
So in our group, we talked about a few things. Definitely this last video was a lot better than the first one. We felt like the interaction allowed much more opportunity for the patient to interact. There were pauses that happened more naturally, but also I think because Abdi kind of created them to have opportunities to ask the patient's input, asked about, if you've ever been told that you have TB, have you been exposed to anyone with TB? I think that those questions are helpful, not just in getting the patient engaged in those questions in particular, but also just at that time, if the patient has other questions that they've been holding on to, I think it's a good opportunity for them to then ask. So I thought that was really great. And then I think we also talked about how eye contact was still hard because a lot of us have been taught our whole lives to always look at the speaker when they're speaking. And I think that was still, it's like hard to break out of that habit and try to look at the patient. So we talked about strategies of where we might put, how we might position the room so that we are looking at the patient more. I think that was the gist of our conversation.
Awesome. Yeah. Any other thoughts? We'll go over some of the specific things briefly.
Sayuli, I just want to call out what you were mentioning about eye contact. I think, it's not just that we're taught to look at the person who's speaking, it is deeply ingrained in us. And where we put our eyes is so powerful. Sometimes, try this out when you're a senior resident or you're even an intern in a room with the student and the patient looks at you. If you move your eyes to look at the student or the learner below you, the patient will then move their eyes to look at that person. And so just by making eye contact, you can bring attention, but it is hard to maintain eye contact with a patient when there's a voice from the interpreter coming behind you. So it's powerful in so many ways.
I'm going to move us forward since we're running a little bit behind. But I wanted to just call attention to this as, the context of every patient visit and what we are dealing with here when we're communicating in English or not in English. We have our physician focus, explaining the illness in terms of taxonomy of disease, and then the patient's focus, their perspectives on their illness, the need for information and understanding, desire for partnership. And the dialogue and negotiation that bridges these two foci, that's where the struggle comes, and that's where communication is key. And so with that, a few tips on using an interpreter. So first off, who can serve as an interpreter? Various types of interpreters. So in the UW system, we have professional interpreters. We also have caseworkers and cultural mediators who take things an extra step. And then we have remote professional medical interpreters who are on video or telephone. These are really our preferred options. The other options that potentially may be used are bilingual staff or family. These are not legally supported. And also it puts, staff members in a difficult position. They may not be certified as an interpreter. It's not necessarily their role to be an interpreter. They have other jobs to do. And then in regards to family members, it takes away from the family member being able to be a family member. It gives them another task that detracts from what their primary role is in the room. And then I'll briefly mention electronic tools, Google Translate. I see this a lot, people Google translating instructions or documents. And this is not recommended because really we can't proofread it and it's not a perfect system. And so you don't know if there's going to be a miscommunication. And so, interpreter services will translate documents at your request if there's some lead time. And then there are various resources that are in specific languages that you could lean on as well. Ethnomed is one particular website that has a number of those resources. How do you prepare for a visit with an interpreter? Sayuli was mentioning the arrangement of the room. And so here's an example layout of an in-person interpreter. So over here is you all, the physician, making eye contact with the patient, and then the interpreter next to the patient. And this makes it so that the patient is really looking back at you rather than looking to the interpreter. So this is one possible layout. And then if you're not using an in-person interpreter and if you're using a webcam instead, this is an example of what that room setup can look like. So the webcam can see both of you. And then, of course, with a phone, having the phone in between both of you so that both can be heard. A few brief tips. So speak directly to the patient, speak slowly and simply, and then incorporate teach back. Teach back really ensures that any errors are caught quickly and corrected. Avoiding idioms, this is something I really struggle with because it's just part of my daily language. Complicated sentence structure, fragments, multiple like stringed questions, and then also changing your idea in the middle of a sentence. It's okay to say, you know, interpreter, just forget what I said, let me restart, and then restart your sentence if you're having to change your idea. And then a bit about errors. So errors in interpreted encounters should be expected, and using a trained interpreter will lower the risk. There's a study, and I think that John Cho is putting it in the chat. This was in the Harborview MICU under optimal conditions with well-trained interpreters, established patients. And even under those optimal conditions, 31% of what are the utterances, so basically phrases, had some type of error. So that's a huge percentage. Only 4% were clinically significant. And the main errors that we saw were omission. And so to lessen the risk of errors, you can utilize Teachback to reveal errors and misunderstandings. But I've included this slide really to highlight the types of errors. So omission, interpreter not including a word or phrase, an addition, adding something extra, substitution, editorialization, and then false fluency. So take a look at this on your own time when we review the slides, but just know that errors are expected and that if we can prepare for that, then you can correct the error. So here are my references. We'll take some questions, but also I think we're running a little bit behind. And so we can also go for a break and then come back at 9:58.
That's a startlingly exact time, Shri. 9:58. I'm impressed.
All right, so take a potty break, and then we'll be here if anyone has questions, and then we'll turn it over to Nicole for our next talk.